Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 112 of Tough to Treat. And before we jump into the podcast, Susan and I both want to wish everybody a very happy new year. And here's to a thriving 2022, right, Susan?
Yes, very much so. We want everyone to have a fabulous year. And in order to help along with our efforts for elevating clinical practice, we have launched our membership, our podcast club.
Yes.
Erica, do you want to tell a little bit about it?
Absolutely. The URL, just so you know, it's also in the show notes. It's HTTPS. I don't think you can put www. It doesn't work.
No, type in
tough2treat.supercast.com. So tough2treat.supercast, supercast.com. That brings you right to the landing page. And I won't go into all the details, but you're going to be getting 2 premium episodes of the podcast in addition to the one that you normally get from us every 2 weeks. One of the episodes will be, we call it a clinical spotlight, interviewing master clinicians on what they do with their challenging patients. I know Susan's going to talk about that more in a second. And then the third episode is an Ask Us Anything episode. And that is your chance to get clinical mentoring from us, on a very live and timely basis. And you can ask us anything, ask any questions you want. It could be business, it could be clinical. We get both. And it's really a way for you to also get together with other community members, because in the portal, you can type in your questions and the answers will be in there as well. And other people can see. So it's really a great way for you to have an exclusive learning experience as well. And I know Susan wanted to talk about.
Yeah, right. So tough2treat.supercast.com. Be sure you go there or go to our website, tough2treat.com, and you'll get the information on it. The link to the membership is in the show notes. And if you follow us on social media, you'll find it there as well. So our first interview, we're just going to kind of give a teaser out there. The first interview that we're going to be doing and really talking about clinical management, which is going to be important, is those tough to treat clients that are post-concussion syndrome. And Erica and I have gone over this and talked about different aspects and facets of this in many of our podcasts, but we thought we'd get the expert Jessica Schwartz, who's going to join us. And she's going to talk a little bit about her new course that she launched as well, in this post-concussion realm. But it's going to be a very, very, very good podcast, and some really good questions, some really good answers, some really good solution-driven information to help us all, because we have so many clients that have not been recognized as post-concussion, and all it takes is a small rear-ending accident to create this that can really wreak havoc in the movement system. Totally. So we're really looking forward to it. It's probably going to be a part 1 and a part 2, so a big beefy one in January and a good follow-up in February. We're really excited, and we look forward to those of you who have joined the podcast club already. Start putting in your questions. So we'll be hopping on to do an Ask Us Anything response very soon.
Thanks, everybody. On to the podcast. Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 112. And let's just get right to it.
The last one of 2021.
Last one of 2021. Oh my gosh. And what an apropos one. This is about elbow pain. We don't talk a lot about elbow pain, actually. But it is a very common issue. I've had it. A lot of people had like ankle sprains. Who hasn't had elbow pain, right? Mm-hmm. So this patient is a patient I've seen before for various issues. And I've treated her for a calf issue, shoulder and neck issues as well. So I'll give you some brief history, and then we'll just sort of dive in. She is in her mid 40s. In September of this year, of 2021, she took a fall on an outstretched hand, a FOOSH, as we call it. It's her right side, her right elbow. Complaints, mostly lateral epicondyle. Took that fall, straight elbow extension. Didn't really sit. She's like, oh, I felt fine. Didn't really bother. No major repercussions. And she was doing a lot of computer use at the time, mousing a lot with her, her index finger, her middle finger, under a lot of stress at work as well. And she realized that when she was doing she started to get back into more of a body weight workout. She was doing like modified push-ups on the floor. That really bothered her elbow. She also does a lot of the those so-called mountain climbers on the floor. That really bothered her elbow. She was on the computer when I saw her much less, about an hour a day. So her symptoms were not as bad, but they were still there. Like she could not do a full push-up on the floor. She can do a full plank, but when she started to bend and straighten the elbow, that's what really bothered her. She also told me that she had a problem doing her hair. So like when she put her hand above her head to like curl it with the brush or the roller, that also bothered it, right-sided. Okay. Besides the past medical history I mentioned about, she did suffer some really significant tightness in 2018 into her right scapula, which I did treat her for. And prior to that, she also had some neck problems, as I mentioned, all treated successfully with physical therapy. Her athletic history, not so much lately, but she does surf. Believe it or not, here in New York. We do have places where people can actually surf, but obviously not so much lately. So that wasn't high on my radar. But that is really mostly her main athletic pursuit, besides the gym, like a lot of, not the HIIT workout, but mostly at home workout at this point in her life. So I took a look at her in standing, and because I know her,
before we go into the exam, I just have a couple of questions.
Oh yeah, go ahead.
When she did the FOOSH injury, the fallout onto the outstretched hand, did she have immediate elbow pain, or did it come on over the next day or two?
It came on after that, shortly after that.
Okay, shortly after.
Yeah, like
and did she hyperextend her elbow when she landed, or was her elbow bent?
It was extended. She is hypermobile and has a lot of hyperextension.
Okay, there's a reason that I'm asking that. We'll get into that a little later, but that's what I wanted to know. Okay, so this is a hyperextension injury of the elbow.
Correct.
Okay.
Correct.
All right.
So took a brief look at her in standing, just because I always do. Nothing really crazy. No major lower extremity except for the calf issues. I had her hands on the wall, just because I was going to do your typical, all of your tennis elbow, wrist extension, wrist flexion, radial deviation. I did all those. They were all negative. Okay. I did all of those. She had no problem sleeping, before I forget, no problem sleeping at all. I checked her ulnar nerve. I had her do it actively. I had her do like the median nerve, all active. And then I had her do a radial nerve glide, which was positive for clicking and popping and pain in the elbow. Okay.
The radial nerve glide?
Yeah, I just had her do flexion, internal rotation, elbow extension. We all do that differently, but it wasn't crazy. It wasn't crazy. She's like, well, that's what bothers me a little bit. So when I had her on the wall, I said, just go put your hands on the wall, because it was the closed chain push-up was like the first thing she mentioned. And I discussed it with her beforehand. I'm like, what do you want to look at? I could get you on the wall. I can easily assess that. Or I can have her do, shoulder flexion, elbow extension. I can do all those. But I wanted just to do like the wrist extension and then differentiate, between the fingers, the finger extension and all of that. So I did that. Everything was negative. I put a lot of resistance through that. And so when she was on the wall, I had her she did okay. I said, just go do a little mini push-up. And she was fine with that. The minute she did that, her entire cervical spine and her upper ribs went right to the right. So she went over onto that side, onto her symptomatic side. All right. And it bothered her a little bit. She could do a plank. She could do, a straight arm plank. She could do a forearm plank. She just couldn't bend and straighten her elbow in a loaded closed chain position.
Okay, so you did her standing with her arms on the wall.
Yes.
And then as she tried to do the push-up, she pulled to the right.
Yes.
Everything pulled to the symptomatic side, even though she wasn't really feeling as much symptoms because she wasn't loading as much.
Correct.
Okay. And I assume you went to hands and knees or
Yes. So
other
right.
things. So I'll let you keep going.
So I had her just do normal, narrow, wide on the wall just because she was there. And I wanted to see if that would add to the picture. Didn't really add to the picture. It was really mostly the bending and straightening. So I had her go on the hands and knees. All right. And so I'm not doing this in the order. Like I just, for people who know me, like sometimes I make people move around a bit, but with her, I know her fairly well. And I was like, let's just do all this in standing. Let's just do all this in sitting. And then we'll go on your hands and knees. So I did check in for the listeners. I did check in sitting also grip, squeeze my hand, which was positive, obviously. I did resisted biceps, brachialis, all resisted, all negative. Okay.
But the grip was painful?
Yes, yes, but not horribly, not horribly. And I just checked shoulder range of motion, hand behind the back, all good, full internal rotation, full hand behind the back, full external rotation, no problem. It's when she put her arm, when she wound up her shoulder in internal rotation and then went into shoulder extension, doing this on the Zoom here, and went and did some internal rotation of the shoulder and shoulder extension in wrist flexion with the fist, elbow extension, elbow flexion, the radial nerve. So that's what before I got her on hands and knees. I got her on her hands and knees, and she's super hypermobile, super like myself, really like significant elbow hyperextension. And the minute she went on to her hands and knees, not like she went back a little bit. She was like, I can do that. And then she went forward. And she's like, oh, that kind of feels weird in my elbow. And she does these weird things with her shoulder. I said, just sort of internally and externally rotate your shoulders, in that position. That was not really symptomatic at all. I actually had her turn her head. I said, can you turn your head? Can you look down? I was had her to move other body parts to see if that would bring it on. Turning her head to the symptomatic side didn't bring the elbow pain on it, brought on a lot of other issues in her shoulder and her neck, which she's had previously. Okay. But this was sort of a wound up position. I'm
just wondering, when you had her on hands and knees and you got her into that closed chain loaded position, did she slide off to the right like she did when she was on the wall?
No.
Okay.
No, that's a good question. I forgot.
Did you do a partial push-up in that position? And she didn't slide off to the right?
No. No, she did not.
Interesting.
Yeah, I know. Context is everything, right?
Right.
It really is. She did not. Actually, I'm just going through my notes here. And what I also did, just give me a second, I actually had her lie on her back because I wanted to see if I could reproduce something with an open chain. So I grabbed a 3-pound weight and I had her lie on her back. And so you're holding the weight like vertically in between your hands. I had her do figure eights, just do figure eights with the weight, 3-pound weight. So you're crossing midline, you're doing, you're gliding and sliding. And that was pretty symptomatic. So that was the open chain, meaningful movement for her. And then the closed chain was more the full push-up. Got her on her back. And I actually did the radial nerve test myself. I tested her median nerve. I did it. I loaded shoulder depression. I had her turn her head. I did it all. And when I tell you, significant shoulder depression, and I had her in the radial nerve position. And I will tell you, Susan, the resistance going through was crazy. I said, can you turn your head? And she's like, I can't turn my head.
Yeah.
She can turn her head. It was literally in shoulder, internal, the whole, people who know, just look up the radial nerve position, wrist flexion, internal rotation. And I literally had her in supine, head neutral, and the pulling through the anterior part of her shoulder girdle was crazy. She couldn't even turn her head to the left.
Yeah, I've got a theory here.
You tell me. Go ahead.
It's interesting because when she raises her arms up to put them on the wall, and then she starts to press through, she shifts to the right.
Yes.
So that's more open chain really than closed chain. It's partially closed chain, but like you said, context is everything.
Yep.
When you change the context and she loads up on the floor, it's different.
Yes.
Pulling is different. I wonder if it's easier for her to access that position of shoulder flexion and loading because she's not raising her arm up and kind of holding it onto the wall. Because when you put her on her back with the figure eights, boom, here it comes. And the thing that I'm having is I'm kind of listening to the story through here. Hyperextension of the elbow may not, maybe the case of like, because that's where the pain is, that's everybody's going to be looking at the elbow. But I'm starting to think between brachial plexus versus cervical plexus, especially with the description you said about her doing it and her willingness to move, which I love. I love that you got her to do the nerve glides first. Yeah. So she understands them. She knows it's probably going to bring something on. What is her willingness to move? That's why we do active range of motion anyway. But then you added in the you did it yourself, and the significant thing was when you pulled her into shoulder depression, or you didn't let her shoulder hike up. That was where everything got super significant, which is making me think cervical plexus, cervical plexus, cervical plexus. In the jam of the fall on the outstretched hand, she definitely hyperextended her elbow, but did that create an axis or an issue with shock attenuation because there wasn't any give in the elbow, so the neck took it all?
Yeah. It's almost like a crush, a crush injury.
Yeah. Just very, very. And the reason that I'm asking this is because I know listeners, a lot of them, think about lateral elbow pain, and and I know they're all great therapists and would go through all of the biomechanics and the movement and everything to see what brings things up. But there's a lot of people out there who kind of almost start thinking, okay, well, I'm going to do that kind of almost in a radial nerve position manipulation at the elbow, and that would be like a no-no with her.
Oh no,
a super no-no with her. But which is why I think it's important, this context piece that you brought up, like what can she do on her hands and knees? What does she do with her arms up on the wall? Because it requires different movements and different movement patterns to put your hands on the wall than to just kneel down on them. Yes. And the open chain with the sliding gliding was symptomatic, and so was the computer.
Yes.
And so, and then of course, then when you really depressed her, that's when that lit up like crazy. So it's now starting to like, we're out of the elbow and we're into.
Right. Exactly. And you think about it, how many people who come in with elbow pain tell you they had a FOOSH injury? I mean, they're usually, it's a lot of it's insidious onset, or I'm moving a movement too much. This was a traumatic injury, right? And you think about it, when you have a FOOSH injury, yes, I mean, it's almost like a rebound, non-rebound type of injury into the shoulder. And I agree with you, because when I had her hands on the wall, and when she did go into the figure eight, with a history of significant issues in the neck, over recruitment of scalene, C6, C7, I had my hands in there, a lot of hypertonicity there. It makes sense. And
if you can see her shift laying on her back, I imagine she pulled to the right, but it's so hard to see with them laying on their back. You can't really see the shifts as much, you can see on the wall, but it was significant that she shifted when she was upright and putting her hands on the wall. So it's not just close chain, because when you got her into close chain on hands and knees, she didn't shift, even with a partial push-up piece that was bothering her.
Right. And exactly. And she didn't shift at all. And, you think about it, people with, I will be honest, so many times elbow pain is something that we see, people wait, and then they finally come in. And at that point, it's not really their elbow. That's not the primary driver. At that point, they come in and see us. And, she's like, oh, thank God. I said to her after, I was like, it's really not your elbow. She's like, oh, thank God. I thought you were going to give me all those stupid exercises everybody else gives. And I was like, no, because it's not going to help.
Yeah,
it's not going to help. Exactly. Yeah. So just for the listeners, what I think about where the radial nerve, where could it get congested? Like you're saying cervical plexus, brachial plexus. That's exactly what I was thinking. Okay. I was like, there's no way that it's, my hypothesis was like, it was something cervical, like a driver up there, whether it's a muscle imbalance, or something up in the shoulder, which is, I think, secondary, but that the main driver or the I would say impairment is the lack of the movement of the radial nerve. Okay. It's not like she's getting, numbness or tingling. She does get clicking at the elbow. I told her, don't worry about that. But when I tell you, so I'm going to fast forward a little bit because she had pretty full range of motion at the neck, but the key with her is I had her in that fully wound up radial nerve position. She couldn't turn her head.
Right.
So I literally just let off some pressure at the, I gave her some more shoulder elevation and she's like, oh, that's so much better. That is typical, right?
Mm-hmm.
But the fact that she couldn't turn her head was really interesting. And so what I did was I'll be quick through here. You, like you were saying, you don't want to do any of those intervention at the elbow there because she's super hypermobile. She's a lot of elbow hyperextension. So even if you're up at the neck, right, and you can, however you guys want to treat the neck is fine. But what I was doing, I just had a little bit of distraction. She's in supine. I gave her some space in between her lower cervical vertebrae. And I just had her, not do the radial nerve glide, but just do shoulder flexion, elbow extension, elbow flexion, neutral positions to see if anything was really turning on. And then I would just do some breath work with her in those positions, how to have her turn her head. I would have her do lower extremity movement. I'd have her, do skull crushers, anything just to get some movement and blood flow up into the tissue up there, whether it was cervical plexus or brachial plexus, head rotation, all of that. I did that. I checked I rechecked. So my self-check was that radial nerve glide in supine in the office. Okay. And so I did that again after I did some of the dynamic release and she could turn her head. It was a lot better. So you know what I did, Susan? I said, grab the 3-pound weight. Let's do the figure eights. Let's see what this does. She did 30 seconds, recheck the nerve glide, way worse.
Yep. Just wound it back up again.
Totally. Like think I'm doing this here. Think about what figure eights does. I mean, it's you're winding the whole plexus up. You're winding the nerve up, right? So I was like, okay. Well, then I had to go back and I had to redo everything. So I said, let's try 2 pounds. 2 pounds was okay. And so I said, I'm not giving her that. I did not give her that to start off with. I basically just had her take a Lysol bottle and just do a little bit of that movement for herself. Okay. Because and then I had her, that was her self-check. Okay. I actually had her do some, easy radial nerve glides, sort of behind her back as a home program. And then I rechecked her in standing. This was the first, I'm fast forwarding about 5 visits now. I had her go on the wall and she was pretty centered after that. So, for the listeners, so she had a TheraBand wrapped around her forearm and I asked her to push out about 5% to do the supine movement series. I give a lot, elbow lifts, skull crushers. That was symptomatic for her. That was symptomatic. So I said,
open chain was not working for her.
No, that was, so I actually started her ironically in closed chain. I gave her wall lands. I gave her dynamic wall lands with your hands, one hand up, one hand down. She tolerated closed chain really well, even though that was her main complaint when I first saw her. Right. But that got better quickly. She's into right now at this point, she's into almost like a full push-up on a park bench. She could probably do a bunch on the floor. But what really gets her wound up is still these figure eights going in out of neutral movement. Anything out of neutral right now still gets her.
Yeah, that's interesting because her history was having some previous problems with the neck and the right scapula. Over recruitment, I would imagine, is why the right scapula was not moving as well. And, then you have a good fall like this. And even though her neck was moving well before, the brain remembers the protection pattern. First of all, a fall is emotional. So you're hijacking the amygdala almost immediately. And when we do that, that ups the protection meter in the brain. And, and it may have just taken her back into an old protection pattern, but now the nerve itself was also being restricted. And as you talk about all the time, they need to move and we need to get blood flow to it. But the trick with her was the initial problem she complained about was closed chain movement, not closed chain planking, but closed chain flexion and extension of the elbow moving up and down, and, kind of feeling it in her elbow and thinking it was her elbow. But if you think about, you can't over recruit from your cervical spine the same way on hands and knees as you can on the wall. I think was what I was hoping I was getting that point across, that even though it's closed chain, it's still open chain. Whereas on the floor, you are definitely moved into closed chain. And so the neck, what was interesting was that it didn't take her into her, context is everything. It didn't take her into her over recruiting business, and it didn't pull her off to the right. She could turn her head both directions. You looked at all of that. And so what you did was, to me, it sounds like you began to expose her to the movement she was having trouble with in many different positions.
Yes.
So we're going to do wall lands, but do them in different positions. Do you have symptoms? If so, let's change it. And let's work out of symptom until you can get it. And of course, she's gotten a lot better with that. But the open chain is going to be the one that's going to be the trickier one to come along, because that's probably where the oil protection pattern is kind of still lying, and trying to get in there and help that begin to change, and the neural tension in that area begin to change.
Yeah, and it's not like. Yeah, and it's not like she had a fall. I mean, let's face it, it's not like she had an overuse injury. I mean, you can always say she's a computer, but a lot of people are computers, and they don't have elbow pain, you know? And I'm just looking at my notes here. I did end up putting those, those orange Franklin balls. I've had them put her in her armpits, and just to give her some space in there. And she's like, "Ooh, that feels really good," And I had her just take, just like literally like 1 pound in each hand. Actually, no, I had her just do I'm holding a water bottle, like a bottle, and just use protraction, retraction, with elbow extension, with the balls in her armpits. And she's like, "Oh, that feels so much better." For whatever reason, that gave her space. Okay. And she has a tendency to over recruit upper trap when she elevates her arm above 90 degrees. That is her history. And I think that for her, she is a little reluctant to go above 90. And I know that's a fear. That's a fear for her. And so we ended up progressing. I took the balloons out, the balls out, and I have access to a fuse ladder up in Pilates, and I had her on her hands and knees. And so she's facing away from the ladder, and she's got the springs. So the springs are behind her, and she's gripping the handles, and she's doing some protraction, retraction, eccentric, just easy back and forth, bending the elbow. I had her do rotation. She was in kneeling. I had her do it in kneeling. And she was like, "Oh, this is what I think I need." And I was like, when someone says that to you, I'm like, you're probably doing the right thing. It's like taking that deep breath, right?
Yeah. And it's nice. It's interesting too, when you think about that, because you could have done that with TheraBand around her back and having her, do that, pushing her, just like you're kind of pushing against a door. For people who are not physical therapists that are listening, just, kind of think about pushing a door, and just using the band as resistance to kind of, expose you to that movement. So you could do that with a wrap band or a TheraBand, or, the Pilates equipment if you don't have it.
Yes.
The pulley system if you've got one at the gym, things like that.
Yes.
The idea is to do it, not have symptoms.
Yeah, like a low weight.
Yeah. And if you don't have the orange Franklin balls that we talk about all the time, they're basically just air balls that are smooth. You can put a couple of water bottles under your arm.
Yeah, a washcloth, just don't grip.
Yeah, what you don't want to do, you want it to be light and moving. And what's nice about that, when you get something underneath the arms up into the armpit or the axilla up there, then you can have them start to do that shoulder, that scapular thoracic movement. And then you can slowly add the neck into that. So you can begin the movement somewhere else instead of going right at the neck, right at the neck, right at the neck, but maybe bust up the knee to over recruit, because it's like, "Oh, this is different. We're in a different position. Maybe we don't need to over recruit here. What are we doing with it here?" It's kind of like taking a movement pattern and putting it, creating, external challenges to expectations. Like, okay, now move your arms. Okay, that feels really different. I think we did a podcast back earlier in 2021. Yeah, it was in 2021, I believe, or maybe late 2020, the gentleman with the shoulder pain, the golfer.
Yes.
And, and one of the things that really, really got him out of his over recruiting was that ball under the up into the
Yeah.
axilla,
Yeah.
and having him just kind of just learn to let that go, and just being aware of the tension, and something that he could do periodically throughout the day turned out to be like his thing.
Yeah.
And it helped his
That's
range of
right.
motion and everything so much, because he had a lot of brachial plexus tension,
Yes.
if I remember
Yes.
right on there.
That's
But
right.
whether it's cervical or brachial plexus, it doesn't really matter. The name of the game is to change the recruitment pattern.
Yes, exactly. I remember that. I remember that episode.
Mm-hmm.
For the listeners, I also had her on her side, and I just got the web space of my hand in her axilla and just had her do shoulder, passive shoulder, elevation depression of the shoulder girdle, and had her, move her arms and just doing dynamic work. I think the more active you become in your exercise program or your movement program with a physical therapist, more movement, easy movement for you tends to be a better way to change patterning versus just sticking your thumb in someone's upper trap.
Yeah.
And that may help initially, but I think in what I've noticed lately and over many years now is that movement tends to be a great release tool, an active movement. And it's patient specific, but with her, I had her do a lot of it. I had hands on, I obviously did, but I was just having her do leg movement, do a clamshell, or, we talked about clamshells. I mean, I just move your legs, plantar flex and dorsiflex your feet. She's hypermobile, right? She's got to have connections, and we all have connections in different regions of our body. So that's what I did to release. And I will tell you, when I had her supine and she turned her head to the opposite, to the left, the pulling was enormous. And that makes sense from what we just talked about. So I think the congestion was somewhere in between, somewhere like on the clavicular fossa, somewhere in there. The listeners, go into the anatomy and look at the course of the nerve. That's where I really think it was with her. And right now I did have her on like the reformer and had her do some knee stretch, hands and knees. She was fine with that. She really was. So, at this point, what I am actually doing, and so for those of you who listen to the podcast, the self-check is a movement that is sensitive to the region of the body that is their driver. And with her, it's her radial nerve glide. It's her active glide. Okay. And that is her self-check. That's the only thing that's meaningful for her. Okay. And I actually make her do that. So I sent her off. I'm still seeing her with, do figure eights. Okay. And I said, you're going to have to go up on that. But you're going to do your self-check after every single, 30-second bout or a minute bout to see if it's worse. Because it probably, as you go up and load, it may be worse.
Right.
And you're not, go ahead.
No, go ahead and finish what you were saying.
No, and I was going to say that if I said, we call it like a reset, which is an exercise that she does really well. Right now, her reset is skull crushers with weight, without weight. It's movement. And I saw her the other day, and I had her like at a high, like 4 to 5 pound figure eight, and her self check was worse. And so I said, just do some skull crushers. She's in supine still. 10 sets. She rechecked it. It was normal. Right? I'm no joke. And she's like, oh my God, that's amazing. I said, so I'm okay if your self-check is worse, as long as you can get yourself out with a reset, knock yourself out. You need to do it. You need to do this.
And that's kind of gets along with loading the sensitivity, the exercise, the driver. At some point you have to load it. She's got to push open doors. She's got to reach across her body. She's got to grab things. She's got to pull things down. The idea is that you want to load it in a way that isn't going to take her backwards, but it's gonna, if she can reset and restore.
Yes, restore.
Then you don't want her to go up. You want her to stay there until that no longer triggers it. And then after that, she does those and it doesn't get worse with the radial nerve check. Now it's time to go up. Let's add some new exercises. Let's do some different things, so.
And that's how your patient progresses.
Yeah.
If I didn't have her do that, she'd be like, oh, my elbow's really sore, or whatever, for like 3 weeks or 2 weeks. You don't want that. You want to empower your patients. You need to do this with your patients. Find out a movement, that's sensitive to the region of the body that's the driver, and have them check that. could be thoracic rotation, head rotation, it could be anything, and have them do that as they should do it from the beginning, right?
Yeah.
But with her, you know, she was able to, because it was so sensitive. I mean, it was immediate in the office, right? And so now she's able to actually go out now with the TheraBand, no problem. The issue right now is just really ramping her up and going in and out of midline. I think she could do a full push-up pretty okay. But I wanted to talk about hers because elbow pain, it's so easy for us to go to the elbow, right? It's so easy, but that's not often the driver. I would say 100% of my patients have elbow pain. It's not their primary driver.
Exactly, like the knee.
Right. You know, and just think out of the box. You know, there's not a set way that we evaluate, you know, everybody, and I've known her before, but I was like, let's get on the wall. Let's just make this a really dynamic evaluation, which it clearly was, you know, because I am familiar with her. So I'm thinking you're pretty okay. I mean, any other things you want to add progressions wise for me, or you good?
I think we're pretty good. I think you kind of have it. It would be fun to get her on the wall and have her start to do, you know, you said she's doing some landing and stuff like that with her head turning.
Yes.
Just to kind of remember that eyes and the cervical spine need to keep going, you know, to kind of help that.
Yeah, it's a great idea.
Yeah. So some of your dynamic movements, be sure that there's, you know, head and eye movement going on as well, just to kind of, you know, bust that up and make sure those systems are coordinating together and not isolating one to do the other, which is always a little bit tricky when we get into that, you know, cervical, you know, scapulothoracic kind of, you know, over recruited, you know, kind of holding pattern.
Yeah. And, you know, for the listeners, when you have your patients going into higher loads, for those listeners who are physical therapists, you know, what I do is I also get my hands on like the driver, and I'm the input, like for her, I did check a full push-up the other day, and I was just giving some just gentle decompression to her cervical spine and her shoulder girdle. And she's like, oh, that feels really good. So that's hands-on, people. That's hands-on. That's the best hands-on of all. You empower your patient to move well. Yes, you know, at the beginning, I had my hands in there and my thumbs were in her scalenes, but she was moving her arms, her legs, it was dynamic. That's how you release muscles that are contributing to the problem, not sitting there jamming your finger into their upper trap and, you know, they're falling asleep on the table. That's not fun anymore. That's not fun for me anyway. So we hoped you enjoyed this episode. I certainly did. And once again, everybody, have a very, very happy and healthy New Year.
Yes. And don't forget to join our podcast membership, toughtotreat.supercast.com. We're looking for you there, answering your questions there. We're even going to be dropping in a few videos. Perhaps we'll drop in the video of the pectoralis, you know, technique to lift up the brachial plexus.
Yes,
Get that in there this next month for those of you who are in the subscription. So join us there.
Yes, a lot of cool resources.
Make 2022 a great year with us. Thank you.